Afternoon, everyone. Sorry I couldn't be there in person, but I'm happy to share this information with you. And it should actually fit in well with exactly what Dr. Linder was discussing about the role of the 3 Bs, of Borrelia, Babesia, and Bartonella. But what I want to share with you is, because we have had a lot of success using Dapsone combination therapy, I want to show you exactly, in the patients who don't get the kind of results that we expect, what is interfering with it. And it's mostly that, and he actually just mentioned this, that the inflammation is coming from many different sources at once. So I'd like to go through that with you so you can see it. I have a couple of disclaimers and conflicts of interest. I have my 2 books. I have received grants from the Bay Area Lyme and from MSIDS Research Foundation, and I have worked on the New York State Department of Tick-Borne Working Group. None of the regimens we're going to discuss today are FDA approved. I do want to tell you, however, though, that I did apply for an NIH R34 planning grant, and I do plan on trying to get the funds from the NIH. Obviously, all the grants were frozen, but they just contacted me, and somebody looks like they're doing a grant. We hope to get the funds by the end of this year. We already have Mount Sinai that's on board, Charles Chu from the University of California, San Francisco, and Andrew Wiles Group from the University of Arizona is also showing an interest. I also, a few days ago, reached out to Dr. Alan Steer from Harvard to find out if Harvard would like to be part of the trial. So we do have some major universities, and I'm ready to go to a multi-center, randomized, placebo-controlled Dapsone trial to show to the world that we actually do have answers for chronic Lyme. Part of the problem, as Henry was discussing, is Babesia, Bartonella, and as I will show you, overlapping causes of inflammation, such as mold toxicity, heavy metals, leaky gut, food sensitivities with mast cell disorders, mineral deficiencies, sleep disorders. I call these the 6 rivers of inflammation. So I'm going to show you in our patient population, having treated over 13,000 chronically ill people during the past 41 years, what makes these people better and what interferes with the treatment. So you already know that the tests are lacking adequate sensitivity. With 8 Borrelia species, that's why we use the immunoblot from IGeneX. Just an FYI, the IgM immunoblots are usually much more positive than the IgG, because when Borrelia invades the lymph nodes, it gets rid of the IgG antibodies, which is in part why we see chronic variable immune deficiency in up to 20% of our patients, and 85% have subclass deficiencies. So a lot of these patients are immune suppressed, and as you heard earlier, it's not just from Lyme, it's also from Bartonella, which I'll show you, as well as mold toxins, which play a huge role in, at this point, suppressing the immune system. And we're also finding long COVID. And long COVID will affect your T cells, and the way also you help to get rid of your viruses. So there's a lot of overlapping factors in the immune system that need to be addressed for people to get better. Borrelia, Babesia, and Bartonella, they all do persist. And we do need biofilm persister drug regimens, as I will show you. I have been in medicine for 41 years doing this with 13,000 patients, as I said. I've tried every different drug combination. The only thing that has worked for me in short courses, without keeping people on long-term antibiotics, without keeping them on long-term herbs, has been biofilm persister drug regimens, including Pulsion, which I'll show you, and I'll show you the 10 articles that have been published in the medical literature for Dapsone combination therapy. We have had some luck with tafenquine for resistant Babesia when people have failed atovaquone and azithromycin, but we've also seen resistance to tafenquine when we use lower doses without using, for example, 200 milligrams once a week instead of 300, and I do exactly what Dr. Linder does. We combine the regimens. We use a lot of Babesia herbs like Chinese skullcap, Japanese knotweed, Cryptolepis, Artemisia, Eichhornia, a lot of the herbs that have been published for Babesia duncani. We use these in our protocols. And when we do find that Babesia is resistant, we usually find that mold has been there, interfering with the way the immune system fights these infections. So what I want to really highlight for you today is that you can have hope that you can get over Lyme disease. My wife is now 7 years in full remission since she did Dapsone combination therapy. She did it 7 years ago. She was sick for about 25 years. I've trained doctors in the protocols I'm about to show you. I will be doing a Zoom conference next week with Dr. Alain Moss and Dr. Charlie Biz from Connecticut. These two doctors are regularly using Dapsone. I will post it on my Facebook page, which is Dr. Dr. Richard Horowitz. You can join the Zoom. I think we'll probably get 100 people on, but I'll record it. And you can listen to their experience also. Dr. Moss sends me emails every couple of months with these amazing stories of kids getting better from Dapsone therapy. So you can have hope, but as I'll show you, these overlapping factors that drive inflammation, mold, heavy metals, long COVID, abnormalities in the gut with mast cell activation and leaky gut, hormone disorders, men with low testosterone or low adrenals, they are interfering with people getting better. So we have to evaluate why people are staying ill. We have to look for not just the bacteria, Lyme and Bart, or parasites like Babesia, but we're finding viral reactivation, like Epstein-Barr virus and herpes virus 6, in many of these patients who have long COVID. And the way we test for long COVID is we use the lab test from Radiance Diagnostics, www.covidlonghaulers.com, and we do the 14 cytokine panel. Now, the problem with this panel from Radiance Diagnostics is that it overlaps people who have Lyme, Bartonella, and other issues. So, for example, if you get an elevated VEGF, vascular endothelial growth factor, it can be from spike proteins from COVID inflaming the vasculature, but it also can be because Bartonella is present, or spike proteins and Bartonella. So you have to keep in mind when you're looking at these protocols that we're about to discuss, we need to rule out mold and long COVID and a lot of these inflammatory factors, because you won't get the full effects from Dapsone combination therapy if you don't find out where all the inflammation is coming from. As I said, the mold is now on the top of the list. We're finding mold toxins in up to about 90% of our patients, and just as heard from Dr. Lindner, almost everyone in our practice has the 3 Bs of Borrelia, Babesia, Bartonella. We'll also look at autoimmune markers, sometimes SNPs and detoxification pathways, especially if they have multiple chemical sensitivity. But the key is, if you're a chronic Lyme patient, or what I call Lyme MSIDS, because it's never just Lyme, it's always these overlapping factors on the 16-point MSIDS model that I'll show you. The thing is that the reason people stay sick is inflammation. So really what you have to find out is where the inflammation is coming from. Some of it may be from the 3 Bs, but some of it may be from leaky gut, from food allergies, the wrong types of bacteria in your gut. It comes from many different areas. And then this inflammation, these 6 main effects of inflammation have 10 downstream effects. They affect your hormones. 99% have low adrenals when they come to see us. A lot of them the men have low testosterone. About 40-50% have POTS, dysautonomia, with fatigue, dizziness, brain fog, anxiety, palpitations. Could look like Lyme and Bartonella, but of course you don't treat it back with antibiotics. It requires meds such as midodrine, fluorocortisone, and salt fluid, limbic retraining to retrain the vagus nerve. And we'll see liver inflammation and mitochondrial damage. So the main slide here that I want you to think about is when we think about inflammation, that any symptom you have, fatigue, headaches, joint pain, muscle pain, neuropathy, brain fog, psychiatric symptoms, it's due to inflammation. That inflammation can come from what I'll call 6 primary rivers of inflammation. Your 3 Bs, Borrelia, Babesia, Bartonella, dysbiosis of the intestinal bacteria, leaky gut with food sensitivities. This shows up in a lot of people because early in life they took antibiotics, they got candida in their gut, and they end up having a lot of food sensitivities, which causes a lot of the same inflammatory cytokines that you see in Lyme and even in long COVID. If you don't get to sleep, and Lyme patients of course don't, they don't fall asleep, they keep waking up in the middle of the night, you can't shut off the inflammatory response, and you get an elevated cytokine called interleukin 6. Toxins with mold especially, on top of the list, and we do find heavy metals like mercury, lead, arsenic, aluminum, and cadmium. These also drive free radical oxidative stress, damaging the mitochondria, causing many overlapping symptoms you'll see with Lyme, and even making the neuropathy worse. And when we look for nutritional deficiencies, not just serum, magnesium, and copper, and zinc, and iodine, but red blood cells, magnesium, copper, and zinc, what we find is at least a quarter of our patients are severely nutritionally deficient. And if you have low zinc, you're going to get a lot of inflammation. If you lack copper, you're going to miss something for an enzyme called superoxide dismutase. You can't handle all the inflammation and free radical oxidative stress. You don't have enough iodine. You're not going to make your thyroid hormones that easily. So on the left side of your screen, these are like the 6 rivers of inflammation going into an ocean of inflammation with these downstream effects of endocrine problems. Because the inflammation affects the pituitary gland, your master hormone, and men get low testosterone. Women can go into early menopause, you'll get low adrenal function, a lot of psychological issues with depression, anxiety, rage, psychosis, OCD. Just about every different psychological problem you see can be caused by Lyme and Bartonella. Again, we see a lot of POTS dysautonomia, which is not just from Lyme and BART, but also from mold and long COVID. All 4 of those will cause POTS dysautonomia. The mitochondria, the part of your cells that makes energy, has nothing surrounding it to protect it like the DNA, which have histones. So that means when we're done with the Dapsone protocol, one of the things we always do is a 1-month mitochondrial regeneration protocol. And then you'll see a lot of pain syndromes. People sometimes come in on narcotics because the pain is so bad, or they came in on gabapentin, Elavil, Lyrica, pregabalin, all of these different drugs for neuropathy. But the doctor never got to, for example, where the neuropathy is coming from Lyme, from BART, from mold, from long COVID, from all these things that overlap. So we always use the 16-point MSIDS map to figure out where the inflammation is coming from, because yes, it's going to be Lyme, but as you heard from Dr. Wigner, yes, BART is showing up in at least 90% of our patients. And if it's Babesia, I agree with him, a lot of Babesia oticolii is now showing up. I did speak to Dr. Shah. We do occasionally see Duncani, but there is cross-reactivity. And you won't get as well with this treatment protocol with Dapsone if you have active Babesia, but fortunately, about 25 or 33% of the patients, if they've not been treated for Babesia and they do the 9-week Dapsone protocol, their Babesia will get better. But it only works at about 25 or 33%. The viruses, we don't just check the titers, but viral reactivation with Epstein-Barr herpes virus 6. We will see West Nile, a flavivirus, overlapping in many of these patients. These are chronic persistent viral infections in that case, and Candida and mold can also be a problem. You have to look for immune dysfunction. If you have an ANA, it doesn't mean you have lupus. It's an inflammatory marker in Lyme and BART. You've got to look for double-stranded DNA and anti-Smith antigens to see if you have true lupus. If you have a rheumatoid factor, doesn't mean you have rheumatoid arthritis. It's an inflammatory marker in Lyme and BART. You have to look for CCP, the very specific marker for rheumatoid arthritis. And people get thyroid antibodies, antithyroid globulin, antithyroid peroxidase, anti-ganglioside antibodies against the nerves, especially when they have neuropathy, and POTS. And the symptoms are worse if genetically they have the HLA-DR4 marker. Now again, with the immune dysfunction, we always check immunoglobulin G, A, M, and E, and we check the 4 subclasses, IgG subclasses 1 through 4. Because many of these patients do have immune deficiency. And if you're immune deficient, you're not going to fight the Lyme and the Bartonella or Babesia the same way. Number 3 on the MSIDS map, inflammation, is why people feel sick. But as I said, the inflammation comes from all the other factors. For toxicity, as I said, mold now is showing up in most of our patients. The test we use is real-time laboratories in Texas. We do a urine mycotoxin test. We give people 2,000 milligrams of glutathione 1 hour before the urine test. Have them drink an 8-ounce glass of water every 15 minutes. And about 15 to 20 minutes before doing the test, they get in a sauna, they sweat, and then they do the urine test. And we're finding these mold toxins in almost everyone. And the problem is, not only do the mold toxins cause the same symptoms you see in Lyme and BART, but it suppresses your immune system's ability to phagocytize, in other words, to engulf and eat these bacteria, which is what your immune system needs to do to get rid of it. Number 5, allergies. A lot of these now environmental allergies, we're seeing them in food allergies with leaky gut, with mast cell activation. Nutritional enzyme deficiency is very common. You expect mitochondrial dysfunction from all the free radical oxidative stress you get from these infections and toxins getting into your body. As Dr. Linder was saying, Lyme and Barth, big psychological disorders and indicators, especially those ones with rage and severe OCD, and even new onset psychosis. We've seen this happen with Lyme and Bartonella. Neurological dysfunction, neuropathy is very common. One of the hallmarks of the way you know your neuropathy is due to Lyme is it's migratory. So Lyme is the only disease in medicine that causes migratory nerve pain. Tingling, numbness, burning, stabbing sensations, or vibration sense in the body, that's neuropathy. Lyme is the only one that causes migratory neuropathy. Lyme also causes migratory joint pain and muscle pain. This was even discussed by Dr. Steer 40, 50 years ago. So that is really a clue as whether the Lyme is still active in your body. And you'll get dizziness, light and sound sensitivity, where people come in with sunglasses, memory and concentration problems, top of the list, occasionally with cranial nerve dysfunctions like Bell palsy. Endocrine disorders, as I said, very common because the inflammation affects your pituitary gland, lowering down testosterone, estrogen, adrenal hormone, sometimes growth hormone, even ADH, where people are peeing all night long because they don't have enough antidiuretic hormone. That is also, by the way, affected by mold. The mold will affect your posterior pituitary hormones. And about 50% of America has insulin resistance, and a third of the whole world at this point has fatty liver, which also contributes to metabolic syndrome and insulin resistance. So when you have insulin resistance, you're going to get a lot more inflammation with blood sugar swings, making your symptoms worse. Sleep disorders happen from Lyme, but the problem is you have to rule out why you have the sleep disorder. Is it depression and anxiety? Is it from having an enlarged prostate? Is it menopause with low hormones? Even young, thin women can have obstructive sleep apnea, and we a lot of times will do a home sleep study by AccuSom, NovaSom, instead of sending them into the hospital to do it, and even restless legs. You have to look for not just, oh, it's Lyme causing it, but why do I have the sleep disorder? Because as I said, if you don't get them to sleep, the inflammatory process will just not show up. We do sitting and standing blood pressure and pulse rates in our practice. So we stand patients after sitting for 5 or 10 minutes after getting a baseline blood pressure pulse, and we stand them. And if their blood pressure is usually pretty stable or it goes down a bit, but if the pulse rate goes up 10 beats per minute standing at 9 minutes, it's mild POTS. 20 beats per minute, it's moderate POTS, and 30 beats per minute or more, it's severe POTS, just like if you did a head-up tilt table test in the hospital. GI disorders, a lot of times, as I said, we find leaky gut, occasionally parasites. One of the things about Babesia is Babesia interferes with the body's ability to get rid of other parasites. So if you have gut parasites, much more difficult to get rid of it because of the way Babesia affects your immune system. 14, elevated liver functions. So what you really need to know is that every different tick-borne disease, Lyme, Ehrlichia, Anaplasma, Rickettsia, like Rocky Mountain spotted fever or Q fever, Borrelia motor disease, all of them will elevate liver functions, but we also find things like alpha-1 antitrypsin, low ceruloplasma with too much copper, high ferritin levels, which is also, by the way, caused by the hemophagocytic syndrome that you heard earlier, which, by the way, is why people died of COVID early on. And I will tell you that the reason we never had one patient die during the early stages of COVID is if you go on my website, www.cangetbetter.com, and you look under the COVID tab, you'll see the protocol we used for COVID. I was the first doctor to publish in the medical literature in April 2020 that glutathione is effective for COVID. Well, it turns out when people were getting these cytokine storms, glutathione not only was helping to lower the inflammation, but the virus needed to lower glutathione to replicate. And we didn't know that at the time. And N-acetylcysteine, which helps you to make your own glutathione, blocks von Willebrand factors, so we didn't get the microclots. People didn't die from pulmonary embolic clots because we were using N-acetylcysteine glutathione. So indirectly, I didn't know, of course, all of this at the time. We didn't lose one person to COVID early on in the pandemic. Long COVID, we are now seeing a few, unfortunately. Pain symptoms, as I said, inflammation from Borrelia mimics every pain syndrome, and many of these patients are deconditioned and need physical therapy. So this model I'm showing you is a personalized precision medicine model. It's patient-centered care. You'll never see two patients that have exactly the same protocols. But the reason I use this MSIDS model, and I've never, by the way, found anything outside the model in all the years. I'm writing my third science book, by the way, right now, from Simon & Schuster. It should be out sometime next year. We're not sure the title's going to change a million times. It's called Why We Stay Sick right now, but it'll change. And it's basically taking not just Lyme, but all these chronic illnesses, the ABCs of chronic disease medicine, ADD, ADHD, autism, Alzheimer's disease, allergies, disease, cancer, cardiovascular disease, chronic fatigue syndrome. And guess what we're finding? The 16-point MSIDS factors are found in every one of these chronic diseases, and it's never been addressed in this chronic disease population. So I'm really excited about this because this is a paradigm shift, I'm hoping, and the way we're going to see chronic illness. So when we published our studies years ago, Precision Medicine, Part 1, retrospective chart review of 200 people on Dapsone combination therapy, or in healthcare back in 2018, the role of the MSIDS model in defining, diagnosing, and treating chronic Lyme PTLDS, you'll notice on the right, when we looked at these MSIDS factors, it was way more than Lyme disease making these people sick. You'll notice at the top there was Babesia Bartonella, followed by Ehrlichia anaplasma, a couple of tularemia cases, a lot of mycoplasma, a lot of herpes viruses, some West Nile, COVID was there, Candida, hypoglycemia, mold toxins. It's more than one thing. It's like going to a doctor's office with 16 nails in your foot saying you have foot pain. The doctor finds one nail, pulls it out, and tells you to come back in a month and see how your pain is. You already know the answer to that. So with the infections, and by the way, this is all published in the 2018 healthcare, which you're looking at this slide now in this table. If you go to healthcare 2018 and search Horowitz, Precision Medicine 2, you'll find us. So we do the laboratory tests, obviously, for all the tick-borne infections. As I said, we're checking autoimmune markers, but also immunoglobulins and subclasses. Also, natural killer cells, CD4, CD8. You want to know how your immune system is functioning. Laboratory tests for inflammation, especially C4A, which is seen in Lyme and molds, VEGF, which is seen in long COVID and also seen in Bartonella. We're testing for serum heavy metals and mold toxins for real-time labs. Allergies, a lot of time we're doing mast cell markers like histamine, chromogranin A, tryptase, prostaglandin D2, while checking the 95 IgG4 food allergy panel from Quest Labs or using functional medicine laboratories. We're checking for these serum minerals and red blood cell minerals, as discussed. There is a test called the mitoswab, where we can check their mitochondrial dysfunction, but we automatically treat when we're done after Dapsone combination therapy. Many of these patients, as you heard earlier, they are depressed and anxious, and some are suicidal. You do have to be very, very careful that these patients have inadequately treated Lyme and BART, and they're under a psychologist and psychologist care when you start treating them for BART because they can get very severe neuropsychiatric purposes. We evaluate all the hormones. The adrenals we do with the DHEA cortisol salivary test. Right? And by the way, these are all, again, in these articles I published and also in my last book, How Can I Get Better? We check vitamin D levels. What's interesting about vitamin D is if you do a 125 vitamin D, which is produced by the kidney, and you look at the 25 vitamin D produced by the liver, and you have a 2-to-1 ratio of the 125 to 25, that's indicative of an active intracellular infection. Now that intracellular infection could be Lyme, it could be Bartonella, it could be mycoplasma species. Doesn't tell you what it is, but it's a clue that it might be there. This was published in 2013 by Mangan et al. Again, sleep disorders, look at diet, hypoglycemia, blood sugar will affect it. Sometimes people are taking ADHD medications like Vyvanse to stay awake during the day. It interferes with sleep because the half-life is so long. And we will do sleep studies, even in young thin women, to make sure they don't have sleep apnea. Autonomic dysfunction, as I said, we do sitting and standing blood pressure pulses. Occasionally, we will send them for tilt-table testing with more autonomic testing, like small fiber biopsies. And some of those patients do need IVIG, but fortunately, as I'll show you, Dapsone combination therapy is very effective for many of these patients with resistant neuropathy. Gastrointestinal dysfunction, you can get vagal dysfunction where you have nausea and vomiting, or you're not moving your bowels for weeks because the vagus nerve can be affected from Lyme and Bartonella. So again, all of these things need to be looked at. And we will do things like GI maps of CDSA to look at the type of bacteria in your gut, just to make sure we're not missing anything in the gut, because the gut, they've now shown, is extremely important for the point of view of your immune function, but also having the right or wrong types of bacteria that are pushing inflammation forward. Elevated liver functions, we're monitoring it during therapy. Pain symptoms, they said, we'll do EMGs and small fiber biopsies, and we will send them oftentimes to physical therapy for deconditioning. So when I see a patient, I want to keep a running checklist of why they're ill. I want to look at these multiple sources of inflammation, the 6 rivers of inflammation, and the 10 downstream effects of inflammation. If I treated them with Dapsone and they tell me afterwards they still have migratory pain, or they get nuclearly advanced on an immunoblot, I know they still must have a little bit of Lyme left in their body. And I'll show you in some cases why this is the case. If I treated them on my HMQ, Horowitz MSIDS questionnaire, which again you can download from my site, cangetbetter.com, if you score a 63, that's very high probability of having active Lyme. Questions 1 and 22 on that questionnaire are suggestive of active babesia. Question 1, do you have day sweats, night sweats, chills, flushing, fevers? Question 22, do you have an unexplained cough or air hunger? So although we don't always see the malarial symptoms, we find, at least in our patient, it's present at least 99%, but we will occasionally see patients where it's not present at all, and most of the time, it is a fish test from either IGeneX or T-Labs, including the new one for the Babesia oticoli that is showing us that the Babesia is active. Regarding active BART, I want to know, do you still have that pain in the bottom of your feet? Do you still have severe neuropathy? Have those Bartonella striae, either white or red streaks in your body that sometimes are perpendicular to the skin planes, have they changed color? The granulomas that might be on your fingers or your elbows, have they also changed size? Do you have an elevated VGF, vascular endothelial growth factor? Fisher PCR, again, telling us the Bartonella is still there. Now, the thing about a positive Fisher PCR, you need to realize, we can lower down the load of these organisms. You could have 1,000 BART, have a positive fish, and you could have 5 Bartonella and have a positive fish because it's that sensitive. But again, we see a lot of patients get better from Dapsone, but the fish can still be positive, and we find it is, if they don't get rid of the mold, that's when 4 Dapsone pulses, 2 pulses for BART is insufficient. It's because the mold toxins usually are interfering with them getting over this infection. So we're constantly following the mold after we detox them for, let's say, 4 to 6 months. We keep rechecking the levels. We want to make sure they're getting to sleep. We look for mineral deficiencies and again checking them for mast cell activation. I just had a patient recently who was very sensitive to a lot of the supplements we're using, and it was from mast cell activation. She was finding that H2 blockers like Pepsid from Famotidine was making her feel better. She was reacting to a lot of these things that are in supplements that most people don't react to. And then we look at the downstream effects of the inflammation. When you stand up, you get dizzy and feel like you're going to pass out from POTS. You have gastroparesis, where you're having nausea and vomiting, severe constipation, bladder issues, where you can't move your bladder properly. That's again the vagus nerve that's been affected. Temperature dysregulation is when the hypothalamus has been affected from this. Presyncope, you're about to pass out and you do pass out. Neuropsychiatric symptoms, again, mitochondrial, hormonal abnormality, resistant pain. We're looking at all of these checklists of MSIDS factors as we're treating. So now let's look at treatment. So what has really made a difference for me in the last 10 years is when Johns Hopkins University about 10 years ago said that, hey, Borrelia burgdorferi is a biofilm persister bacteria. We knew that Lyme persisted, but we didn't know that it was what's called a persister bacteria like TB or leprosy. That we did not know. So immediately I jumped on the bandwagon and I looked at tuberculosis drugs, which I wanted to use for years. I used them in residency when I was seeing HIV patients who were coming in with a lot of Mycobacterium avium complex or coming in actually with TB. So I had a lot of experience using rifampin and pyrazinamide and these different drugs, and I was interested to use them. We know that the literature tells us that there's been treatment failures due to persistence of Lyme borreliosis. There's hundreds of articles at this point. It's ridiculous. That's why when they tell you we don't know if Lyme is persistent, that's medical politics, that's not medical science. But what they found in the Johns Hopkins research is when they did culture studies, they found that 4 drugs work better than 3 drugs work better than 2, and 2 drugs work better than 1. So they found that Dapsone was effective against Borrelia burgdorferi stationary phase persisters. But what was exciting about their research is that if they did Dapsone minnow cefuroxime and zithromycin, or Dapsone rifampin minnow cefuroxime, it had the best activity against these stationary phase biofilm forms that again was the major form of where the inflammation was coming from. So I called Eva Shafi at the University of New Haven and said, Eva, I want to replicate these studies and take a look at Dapsone alone in culture, because I already published some of my articles on Dapsone alone and in other combinations and found it was working, but I didn't actually know for sure was it working against these biofilm persister forms. So what you're seeing here on the slide in the upper left is at 72 hours, this is what a culture looks like. You can see doxy alone, which is panel D. It's a fairly large biofilm at 72 hours. If you look at Dapsone, you'll notice Dapsone is actually more effective than doxy. But now go down to the bottom right panels, K and L. Look at triple therapy with doxy, rifampin, Dapsone at 72 hours. You'll notice the biofilm persister forms are much lower. And if you add a 4th drug, again confirming exactly what Johns Hopkins found, we found that it lowered the biofilm persistent forms by another 3%. So what it found is that Dapsone alone worked, but Dapsone was better. Rifampin Dapsone worked even better, and the best combo was Rifampin Zithro and Dapsone. That had the most significant effect in reducing the mass and viability of these protective mucopolysaccharide ladders of Borrelia burgdorferi biofilm. And those findings explain, at least in part, the clinical efficacy we've seen in the Dapsone trials. Then what was wonderful is I didn't have an animal model to prove whether this works. So 2 years ago, Monica Embers at Tufts, she did an animal model and proved that dual combinations of rifampin and Dapsone completely eradicated Lyme. So although we can't 100% say that the protocols I'm about to show you will cure Lyme, we now have culture studies, we have animal studies, and I have, at this point, up to almost 400 patients in 10 studies on Dapsone showing its efficacy. Now, before we put people on Dapsone combination therapy, DDD stands for double-dose Dapsone combination therapy. That's the 8-week protocol. With a second month, you use 100 of Dapsone twice a day. We finish it off with ECTCT, high-dose Dapsone combination therapy, 4 days for chronic Lyme, 6 days if you have chronic Bartonella. But what we do is, and this is already in the protocol, which by the way was published in the medical literature, September 2023, in the journal Microorganisms, look it up by Horowitz et al., I'll show it to you on the slides. The entire protocol is in there so your doctor can use this. You do not have to call me up on the phone and ask me how to do the protocol. It's already published like a cookbook in the medical literature, and I'll show you the last slides today. I've also published it on my Medical Detective Substacks, which are free to sign up in great detail. The whole protocol is discussed in detail. So we block NF-kappa B with NAC alpha-lipoic acid glutathione. We stimulate another anti-inflammatory pathway with curcumin, turmeric, sulforaphane glucosinolate, broccoli seed extract, resveratrol, and organic green tea. We block chemokines. We work on the nitric oxide pathway. We work on bradykinins and prostaglandins. A lot of these patients are on montelukast acid and omega-3s. A lot of them have mast cell disorders, so they're on H1H2 blockers with Zyrtec and Pexid, cetirotine and famotidine, but also on histoquel, quercetin, PDA-luteolin, and chromolan sodium, because we have to block the mast cell activation, another form of where the inflammation is coming from. And then we block another inflammatory pathway called the NLRP3 inflammasomes using low-dose naltrexone and very low-dose melatonin like a milligram of bedtime. So again, before you start the Dapsone protocol, we're blocking NF-kappa B, we're inhibiting NLRP3 inflammasomes, We're using low-dose naltrexone to block these microglial cells in the brain that turn on the brain inflammation. We're doing anti-inflammatory diets like Mediterranean diets, but avoiding your sensitive foods, keeping down the sugars and gluten in many people, replacing the minerals, getting you to sleep. We'll talk in a second about how we treat the infections. We're working consistently on detoxifying the environmental toxins and mold in between the protocols or before, depending on how high they are. We're balancing the hormones. Most of these patients are on adrenal support when they're doing Dapsone combination therapy. We're balancing the microbiome. We're using over 500 billion of 4 different probiotics twice a day, over 1 trillion different probiotics of these different strains, over 18 different strains in patients. We have not seen a case of C. diff diarrhea, and we hardly ever see yeast as long as people are sticking with the protocol. We repair the mitochondrial damage at the end, and we tell people if they've been traumatized, if they've gone to 20 doctors holding them it's all in their head and you've been gaslit, or simply because there's been trauma early on in life, as many of my patients have had, we really encourage them to meditate, to do limbic retraining with the anti-hopper dynamic flow training, with the AIR, amygdala insula retraining, or primal trust. This limbic retraining is very important to heal the mind and heal the emotional state, because the immune system also responds to this. If you've been damaged and traumatized as a child, as over half of my practice has, it's almost like a part of your immune system says, in my wife's Italian, mea culpa, like I don't deserve to be better. And of course you do, right? So, let me show you some of these studies we did on chronic Lyme disease and using Dapsone combination therapy. So one of the largest studies was a retrospective study of 200 people who did chronic Lyme, and we wanted to find what exactly is chronic Lyme disease. As I said earlier, for me, it is Lyme MSIDS. It is Lyme with these 16 overlapping factors driving inflammation. Again, when we did our initial study, you'll notice most of these MSIDS factors were positive, which is why the people were staying ill. So again, as we're treating the people, we had to keep stratifying the MSIDS factors, keeping them ill. Now, always at the top, it was always chronic Borrelia babesia bar, always, right? And you'll notice over to the right on the slide, there's your persistent drug regimens. You're either using Dapsone combination therapy or rarely disulfiram, which I've had some luck with low-dose disulfiram, and of course, anti-malarials. But right after chronic, the 3 Bs is mold, where we have to use things like phosphatidylcholine and glutathione, with binders, with clay, charcoal, glucomannan if you have trichothecines and minerals. Chronic insomnia, we've got to get you to sleep, right? So we might use Lyrica, pregabalin, or Gabatril, which we can mix with methylene blue. I don't use a lot of Lyrica, Ambien or Lunesta. I don't prescribe them much anymore, but you can't use a lot of the sleep aids that most people use because they will interact with methylene blue, and I'll explain this in just a second. If you have food sensitivity, leaky gut, we're using things like bovine immunoglobulins, H1H2 blockers, right? Blocking mast cell activation. We're treating your hormones with, a lot of times, adrenal glandulars and herbs. If men have low testosterone, we're using things like Clomid and Arimidex instead of giving them testosterone shots or cream, by stimulating the pituitary to make luteinizing hormone, which increases testosterone. We replace their minerals, their vitamin deficiencies. We're treating their POTS with salt, fluids, midodrine, vagal retraining. Again, we do the mitochondrial regeneration. Psych issues, EMDR, cognitive behavioral therapy, limbic retraining, and again, working on their immune system. And really, the reason we need to use these protocols that I'm about to show you is 41 years in clinical practice, having tried Doxy and Zithro, and doxycycline, which is a persistent drug, and using IV drugs. These biofilm persistent forms is the shortest, quickest way I know how to get you better without staying on antibiotics or herbs for the rest of your life. And as I showed you earlier, this comes to remember, single drug regimens do not eliminate Borrelia. It is the combination therapies which ends up clearing Borrelia. So when we look at the combination we use in Dapsone combination therapy, the reasoning behind it is the tetracyclines block the 30S ribosomal subunit, shut down the bacteria. Macrolides like Zithromax hits the 50S subunit. Rifampin hits both actively growing bacteria and persisters, as per the yin-yang model in tuberculosis. I use pyrazinamide quite often. It's a tuberculosis drug that kills persisters and shortens the treatment course. We found that in an earlier study I published on BART, it looks like it has potential for shortening the course of Bartonella treatment. We need a lot more studies to prove that, but I do use it regularly. Methylene blue not only lowers the side effects of Dapsone with high methemoglobin, but it's a persister drug. So we use it all the time with Dapsone combination therapy. And of course, Dapsone is a persister drug used for leprosy. They give people rifampin Dapsone for 1 year, and they cure leprosy. The fact that I have patients now for years in remission, I suspect in some people we are curing them. And the ones that are not cured, they always have Babesia bark, they always have mold, they have long COVID, they have these overlapping MSIDS factors. But the beauty of Dapsone is I mentioned to you that every symptom you get with chronic Lyme is from inflammation. Dapsone is anti-inflammatory. Dapsone has anti-malarial properties. Some of these people get better with Babesia. It decreases autoimmune manifestations, which we see all the time in Lyme. It has fabulous central nervous system penetration. I have not had to use an IV drug in years. The last time I had to do it was about 5 years ago when someone was on Dapsone and had a Bell's palsy. And this is actually it was interesting, it was Borrelia mayonnaise from the Midwest. The guy had a maculopapular rash, it was from a different species, and I had to put him on IV Herceptin for a month. Other than that, I never have to use IV therapies. And it fixed persisters. So how do we prevent the side effects of Dapsone? Because you're going to get very severe herpes reactions when you open up the biofilms and you hit these persisters. Well, it's, again, using low-dose naltrexone. BLT formula with Smilax or Sapozola lowers herpes. Lots of glutathione, up to 2,000 milligrams 3 times per day, while alkalizing the blocked body. And then we block these inflammatory pathways, as said earlier, to make it easier to get through the protocol. We also start with very low-dose Dapsone the first week at 25 milligrams. It can be every other day the first week, too. Now, what about the anemia? A lot of doctors don't want to do Dapsone about the anemia. Well, most people will drop on an average about 4 grams of hemoglobin. But as I'll show you from the published studies, and I'm going to let you know honestly, there's never been one case where the anemia did not come back to normal. You are being foolish if you do not use this protocol. If you would rather live with a chronic persistent infection instead of getting temporary anemia or a mild elevation of methemoglobin, it makes no sense to me whatsoever. But you've got to reverse the iron deficiency before you do Dapsone. You've got to reverse B12 deficiency or folic acid deficiency. But you are going to drop about 4 grams, and I'll give you a worst case scenario. I had a woman 3 weeks ago. She's been ill for a good 10 years. And she's seeing my nurse practitioner, John. I decided to take her over the family. This is my last year, by the way, of one-on-one clinical practice. I'm moving to just a consultation model, where if your doctor needs my help next year, I will work with your doctor to do Dapsone combination therapy against this model. You just contact my office, medical@hphac.com. So this woman had never gone through double-dose Dapsone. She had tried it, but she kept dropping her hemoglobin. Well, she started with a hemoglobin close to 13. She got in double-dose Dapsone, and around the 2nd week, she was at 10. But the 3rd week, she had her menstrual cycle. We repeated her count, she was down to 7. So this woman dropped 6 grams of hemoglobin by the 3rd week of double-dose Dapsone. I stopped the Dapsone. I upped the leucovorin and Zacro, which is L-methylfolate, to 6 twice a day. 1 week later, she went from 7 to 10.2 hemoglobin. I checked her counts this past week. She's 13.4. We never have had to do blood transfusions. The minute you stop Dapsone and you leave people on high-dose folic acid, and the worst case scenario is what I just told you, and it's about 1 out of 100 people, usually women who have a menstrual cycle during Dapsone, that is the average drop is 4 grams, but it'll be worse. You stop the Dapsone. She is now telling me, she just emailed me, she said, Doc, I'm feeling the best I have felt in 10 years, even though she only got through 3 weeks of the double-dose Dapsone, and now she's working on her mold. So in her case, the mold was not the biggest factor making her sick, it was the Lyme. So again, please do not be afraid of this, it always comes back to normal. But you've got to check the G6PD level. G6PD is glucose 6-phosphate dehydrogenase. It is an enzyme. If you're missing it, your blood cells will kind of burst apart with hemolytic anemia. I've only had 2 people in 13,000 that did not have a G6PD, and one of them, his hemoglobin was 16.5. I still gave him the Dapsone protocol. His anemia was no worse than anyone else, and he got better. Rashes, if you've ever had a sulfur sensitivity to Bactrim, sulfamethoxazole trimethyl, you might say, well, I can't take Dapsone, it's a sulfur drug. Fortunately, only 1 out of 100 people cannot take it, and even that, it's even less. We just give them Zyrtec and Pepsid, we block H1H2 receptors, and we give them Dapsone. And we just start with 1 pill on H1H2 blockers with quercetin, histoquel to make sure we're keeping down mast cell activation. If they don't get a rash, we wait a few days, we give them another Dapsone. So we'll go very slowly to make sure they don't get rashes, and then if they're fine, we slowly ramp it up, and we just leave them on an H1H2 blocker. We'll give them a Medrol dose pack and an EpiPen to hold on to if they've never had to use it in all the years I've been doing this. The hemoglobin levels, which is where you don't carry oxygen well, we have managed to now control this because the way I've designed the protocol is you're going to be on 6 or 7 different things to lower methemoglobin. As I said, methylene blue lowers methemoglobin, and by the time you get to the last part of the protocol, 300 milligrams of methylene blue twice a day does a fabulous job of lowering methemoglobin. The average increase in methemoglobin on double dose or high dose Dapsone is 5 to 6%. That is annoying. That is like, hey doc, my fingers and toes, they look a little bluish. I'm a little tired, I have a slight headache, I look a little pale. Okay, the worst methemoglobin I've seen lately was someone at 8,000 feet in Aspen, Colorado who did this protocol. Their methemoglobin was 17-18%. They still got through the entire protocol. The only time you have to stop it is if it's over 20%. But the way we reverse methemoglobin is we give you cimetidine. It's an old H2 blocker that lowers methemoglobin with methylene blue. Glutathione lowers methemoglobin, and so does vitamin C, so does vitamin E, and so does an antioxidant used for mitochondrial support, E-NADA or NADH. So you are on multiple nutritional supplements and drugs to lower methemoglobin, and therefore we really don't find it to be a problem anymore because we've been tweaking these protocols for the last 10 years. We would only stop the Dapsone when methemoglobin got above 20%. As I said to you, the hemoglobin parameters always come back to normal. So here's something that may concern your doctor is they do the CBC in the middle of Dapsone, and they get these things that show up in the blood called myelocytes or metamyelocytes. So what are myelocytes and metamyelocytes? They are precursors of the red blood cells. Now initially, years ago, I went, oh my God, what's going on here? What is Dapsone doing? Well, Dapsone is affecting folic acid synthesis of your red cells. It always goes away over time, but what was interesting in the studies, and I need larger studies to prove this, but the people that actually had the elevated myelocytes and metamyelocytes had the best response to Dapsone. Now that may be coincidental or not, I can't tell you, but in either case it never made a difference and it always came back to normal. So there are 10 Dapsone studies that are now published in the medical literature. There's very few cases in the medical literature where we have culture studies, we have animal studies, and we have approximately 400 people in retrospective clinical studies, and I've applied for an NIH, as I said, 34 grant. I'm hoping to do it next year. That is now the future of my medical practice, is doing consultation medicine and running a multi-center placebo randomized clinical trial. What we do with Dapsone is not just give it for 9 weeks, is we pulse it. And this is where we help Bartonella. Because the medical literature has shown that when you pulse dose these antibiotics, you decrease biofilm formation, and that's why you do it. If you want to read about the efficacy of double-dose Dapsone, this was published in the journal Antibiotics, October 2020, and the efficacy of short-term high-dose pulse Dapsone, this is 4 days of high-dose Dapsone after the 8-week Dapsone protocol, that again was published several years ago in the journal Antibiotics. Now, when we gave the Dapsone protocol for 8 weeks, and we finished it with a 4-day high-dose Dapsone pulse, that means 200 of Dapsone twice a day, and that's, by the way, the most difficult part of this protocol. The majority of patients noticed sustained improvement in fatigue, pain, headaches, neuropathy, insomnia, cognition, and sweating. But what was fascinating about the study, it was the Dapsone dosage, not the treatment length, that affected outcome. 84% had improvement in the tick-borne symptoms, and about a third went into remission, even if active babesia part was present. And what we saw with symptom improvement was number one, cognition. Almost 70% said my memory concentration got better, followed by joint and muscle pain, fatigue, headaches, neuropathy, insomnia, sweat chills, that was the babesia, palpitations, tinnitus, ringing in the ears, shortness of breath, and one patient said visual snow. And what we found is the layers came off in resistant symptoms. So once we did this 8 to 9 week protocol, if we then gave them a 2-week antibiotic course, finishing the last week with 4 days of high-dose Dapsone, when we finished, they would say it was like peeling an onion. Like, hey doc, the neuropathy didn't get better in that last course, but now it did. Oh, but I still have fatigue and cognitive issues. And then 2 months later, we did another 2-week pulse with the last week being 4-day high-dose Dapsone. Hey doc, now my fatigue is better. Oh, but I still have headaches. It was coming off like we were peeling an onion. But we found that those 4-day pulses did not work for Bartonella. So I went back to the medical literature looking at Johns Hopkins research. They found that you needed a minimum of 6 days of these persistent drugs in culture to eradicate the biofilm forms of Borrelia hamster. So rifampin and methylene blue and azithromycin in the Johns Hopkins study completely eradicated the biofilm form, and that is exactly what we're using in the Dapsone protocol, is zithromax, rifampin, methylene blue, with, for example, doxycycline and Dapsone. And again, methylene blue has persistent effects. We publish this, you can find the exact protocol that your doctor can use without ever coming to me for my consultation model. It's in the journal Microorganism, September 2023, comparison of the efficacy of longer, meaning 6 days of high-dose Dapsone, versus shorter, 4 days of high-dose Dapsone, pulse therapy in the treatment of chronic Lyme, PTLDS, with Bartonella, and associated bone infections. So what were the results of these 6-day pulses? It didn't matter how old you were. It didn't matter if you had this illness for 2 years or 30 years. It didn't matter if you were a man or woman, equal numbers went into remission. A 6-day high-dose Dapsone pulse was definitely superior for BART. Now in general, for Bartonella, we need 4 of these high-dose Dapsone pulses. It's 2 weeks of antibiotics. The last week is 6 days of high-dose Dapsone. In most people, they need at least 4 of those pulses to put them in remission for BART. But what we're finding is interfering is mold number 1 and long COVID number 2. 100% of those BART patients improved their underlying symptomatology. Fatigue, pain, headaches, cognition, even the pain in the bottom of the feet, their striae and the BART pseudoseizures in some people got better. The sickest people were always the one that had several Babesia species and Bartonella species together. They were the ones with the worst neuropsychiatric symptoms, the worst neuropathy, the worst POTS dysautonomia, and the worst immune deficiency. And if you go back and you read my study in September 2023, we found up to 4 different Babesia species, 6 different Bartonella species, and 80% of those people that were FISH positive for BART, those were the species of Babesia Bartonella that were showing up. And those were, again, the patients who said, I got the worst depression, anxiety, psychosis, or bipolar disorder. I have the worst neuropathy or POTS dysautonomia. These were the people with chronic variable immune deficiency on IVIG or subcutaneous immunoglobulins, or they had chronic inflammatory demyelinating polyneuropathy. So if you have someone who is super, super sick, always suspect Babesia Bartonella, exactly what Dr. Linder was talking to you about. And again, the Lyme Bartonella symptoms overlap. The difference is the neuropsychiatric with BART usually is much worse. You get these very classic skin lesions. We get granulomas with Bartonella, and we've seen it. The pain in the soles of the feet is very, very classic. So finishing up, our best approach at this point for treating chronic Lyme disease with resistant BART is to do the Dapsone protocol, which is an 8-week oral antibiotic generic protocol. And if Lyme was there, we would use, without BART, we would just use 4 days of high-dose Dapsone. But if BART is there, we finish it with a 6-day high-dose Dapsone pulse. So again, based on the culture studies I showed you, it's usually low-dose minnow 50 twice a day, Zithromax, rifampin, methylene blue, again, hidden part, pyrazinamide based on body weight. You've got to get off all your psychiatric medicines, by the way, before you do methylene blue. And you also have to get off, for example, histamine foods. You have to watch your blood pressure. And we address the bladder issues usually with things like phenazopurity. But again, you need usually a minimum of 4 of these pulses 2 months apart, because we've got to wait for the anemia to come back to normal. Once the anemia comes back to normal, in those 2 months that they're recovering from the Dapsone-induced anemia, we're pulling out the mold. So when they're not doing the pulse therapy, they're pulling mold. Then they stop the mold therapy, we put them on a 2-week antibiotic pulse. When they stop the 2-week pulse, and we're reversing with Dapsone anemia, we go back and we pull out the mold. We just go back and forth, and we're using 4 biofilm agents at the same time. But in this last clinical study, when we compared the 6 to 7 day pulse, 100% of all patients got improvement in their tick-borne symptoms, which is almost unheard of. About a third had full resolution of their Lyme symptoms for 3 months or longer, even if active Babesia bartonella were present. And the reason you need to consider doing these pulses is we've had people in full remission that we thought, hey, they're good. And then, for example, the guy on the left went into the emergency room for what he thought was a cellulitis, a skin infection. He had been a year in full remission. They gave him augmentin for cellulitis, and all of a sudden, these stretch marks came out on his abdomen. There was his bartonella that was hiding for 1 year, where he felt completely well, by the way. Why? Because we had lowered the load of the biofilm persisters, and we had addressed all the MSIDS variables, so he was feeling great. But DART was still there, and it came out. We pissed it off when they gave him the antibiotics for the cellulitis. The one on the right, she was already doing much better after Dapsone, but her Bartonella granulomas on her hands, you can see them on the left, was still present. When we did a pulse with 6 days of high-dose Dapsone, all of a sudden that big red area, which is on the left part of her hand, to the right now, it started shrinking, getting better. She did not have an improvement in this until she did the 6-day high-dose Dapsone pulse. We found that the higher dose methylene blue dosage is superior for Bartonella. It's better for lowering methemoglobin level. It's better for these Bartonella patients that are FISH positive with an elevated VEGF. The number of pulses I've ever had to do was 7 or 8 pulses, and that was in someone in Europe that had the highest levels of mold toxins, 50 times above normal. It was the highest levels I've ever seen. But again, you've got to get off your psych drugs, your SSRIs, your SNRIs, your MIO drugs. You've got to get off to avoid the potential of serotonin syndrome, and I always use a PDR drug checker for interactions. So to get people to sleep, I use Lyrica, pregabalin, gabapentin, Gabatril. That does not interact with methylene blue. I do not prescribe Valium. I do not prescribe Lunesta or Ambien. They can be used. I just don't prescribe them. And the way we control the side effects of methylene blue with the blue urine, when you can get burning, feeling like you have a urinary tract infection, is an old drug that's used for urinary tract called pyridium or phenazopurity. It controls it extremely well. Right? But again, we're getting them off psych drugs, we're following their blood pressure, they've got to be off high histamine foods and high tyramine foods. All of this, by the way, is in the article that I published and in the Medical Detective Substacks, which I'll show you in just a second. So in a study that we published last year, we followed up on several of these cases of post-Dapsone therapy with several doses of high-dose BART, and all these people, by the way, were BART FISH positive. They're now in remission for over 2 years, actually it's over 3 years at this point, despite being chronically ill for many years, but the key was all the MSIDS factors had to be adequately addressed. So the best treatment we have now at the Hudson Valley Healing Arts Center are pulsing these persistent medications. We use double-dose Dapsone. If there's no active Babesia BART, it's an 8-week protocol. If there is chronic Lyme but no Babesia BART, it's a 4-day pulse. If there is BART, as there is in now 90%, you finish off the 8 weeks of double-dose Dapsone with 6 days of high-dose Dapsone. Now let's say you got anemic, like this woman did, the 3rd week of double-dose Dapsone, you couldn't finish. You just stop the Dapsone, wait for the counts to come back, and then go to a 2-week Dapsone pulse, because now you're only using 6 days of Dapsone at high dose when the counts are already at 13.5. So even if she drops 3 or 4 grams, it's not a big deal. She'll be back very quickly because you're only 6 days on Dapsone. So what about these resistant patients? As you heard earlier, they're almost always active Babesia. Look for those malarial symptoms. It almost always have active Bartonella. The mold is at the top of our list at this point with metals and long COVID. And the problem now with long COVID is I've tried the Patterson protocol with Maraviroc and atorvastatin. It hasn't worked for one person out of 25 or 30 people. Unfortunately, all of those people have mold and Bartonella. So maybe it works. Patterson's telling me he's getting help. I haven't seen it help in one person. So the FLCC Alliance is talking about using fibrinolytics, nicotine receptor agonists. There's a whole bunch of stuff out there. Unfortunately, none of it's published in the peer-reviewed medical literature. So I'm going to do a search soon to see what else is out there. But after spending billions of dollars by the NIH on long COVID, I'm surprised we don't have better published research at this point. But if you are still sick, please look at all these MSIDS variables. That is what is keeping people ill. And Babesia, if you fail the classic protocols like atovaquone with Mepron, and by the way, years ago we used to find it used to get some help when we would use Bactrim and these herbs, consider it epinephrine. When we do 200 milligrams a day for 3 days in a row, and we use the higher dose of epinephrine weekly, which is 300 milligrams, not 200, we sometimes get better results, but a lot of times we use Malarone for a day. And all these Babesia herbs, like Dr. Lilly was saying, we're using a lot of things for Babesia at the same point in time. Real-time lab, we're detoxing, as I said, using phosphatidylcholine and binders, and there again is how you test for long COVID in there. So it is free to sign up if you get Substack on your phone. There's no cost, it's free to sign up. I published at this point 3 Substacks online, 3 on Babesia and 5 on BART, and the last 2 on BART, number 4 and 5, explains the double-dose Dapsone and high-dose Dapsone protocols in even greater detail than what is published in the medical literature that I showed you from Microorganisms 2023. So thank you for your attention, and now I'll take some questions.
I'll go with Dr. Horowitz. How do we have to talk? Can you hear me?
He can see if you're right in front of the camera.
You better come close. First of all, I'm getting old.
Oh, yeah.
I think all the rock music I had when I was young is affecting my hearing. Pleasure at the back of the room. That's right.
Hey, Richard. Henry.
Good to see you, Henry.
I think Dapsone has good potential against all 3 organisms, right? I know it's effective against Babesia. I've seen it work. And that's one of the primary benefits. It's just, it has this, multi-species effect. Correct? All right. Thank you very much.
Oh, it's my pleasure. And look, I agree with you 100%. The 3 B's are showing up in everybody.
Yeah.
It's almost no one at this point that is not having Babesia Bartonella that we're seeing. There's no such thing as chronic Lyme without these co-infections. It's showing up in everyone.
And I think they're so common in the population, and maybe you agree, many people are relatively asymptomatic or have very few symptoms, but they have these infections, but you know what happens, they get something else going wrong, and then they become
what I suspect has happened with a lot of these people is they got flea bites when they were young with BARD, or cat scratches, or from spiders and mosquitoes. I mean, red ant bites are showing up in multiple vectors.
Yes.
But the immune system was able to handle it. And then what happened is, they got mold exposure, which pushed out their immune system, and they got Lyme, pushed out their immune system, they got BART, pushed out their immune, and then all of a sudden, they can't handle the BART. That's why I think the BART it's basically showing up in immunosuppressed individuals, and long COVID is not helping matters because we're finding the T cell dysfunction, where they can't get rid of the viruses. So it's all of these infections with the immunosuppression. I think most of us have been exposed to BART, but with healthy immune systems without Lyme, it's not coming out.
Yes, yeah. I got tested myself recently. I have some Bartonella antibodies. I have Babesia antibodies. And
I don't even want to check myself. I feel well. I don't want to know. I do not want to know.
All right, thanks for the info.
That's good.
Good to see you.
Anybody else?
Was my presentation that clear that none of you have any questions for us?
That was great. We loved it. A lot of information. Yeah.
If you could come closer to the microphone, it's easier for me. Or bring a mic to you.
It was a great presentation. It's Maggie, and we're so glad that you were able to join us today, even if it's virtual. You spoke at our first conference 10 years ago. So it's been 10 years this conference, so we're very happy that you were able to join us.
Oh, it's my pleasure. You know, it's funny that 10 years ago is when Hopkins was first reporting this. My first study on Dapsone was 2016.
Wow.
So it was right at the time when I was speaking to you guys the first time. I was like,
Yep.
looking at this stuff, seeing it was helping, but I didn't have any published research. And I mean, the good news is we've really made a lot of progress, and I expect to get this randomized trial done next year. I was surprised to hear from the NIH last week that instead of the grant freeze, somebody from the study section is actually looking at the grant. My 501c3 paid a research foundation in South Carolina. You can't believe what it takes to get an NIH grant in there.
Sure.
It was 4 months of filling out forms and doing this. But I mean, I'm thinking it's going to happen. And you know, the joke is, when would I ever invite Alan Steer
There
or
you
someone
go.
like this? And I'm trying to bring everyone into the fold to say, come on, guys, let's work together and let's just get this done, because science is being attacked right and left, right? Recently in this administration. So, and Harvard stood up recently, right, with some of the points of the politics, but it's like, hey, maybe Harvard even wants to be on board at this point. So thank you for inviting me, Maggie.
Thank you.
It's my pleasure.